Welcome to the EADV podcast. In today's very fitting episode, Professor Jan Guttermuth is joined by Professor John Paoli, who heads up the Dermatology department at the University of Gothenburg in Sweden and is an expert on skin cancer. In this episode, they discuss his research on skin cancer, including treatment aspects and epidemiology of both melanoma and non-melanoma types, emphasizing the significance of prevention, early detection, and effective treatment options. You will gain valuable insights on educating patients about protecting themselves from skin cancer and providing optimal care in case of diagnosis. But first,
get ready to experience cutting-edge science and innovation in dermatology and venereology at the upcoming EADV Congress in Berlin, Germany, 11th to 14th of October 2023. The EADV Congress is one of the largest and prestigious international gatherings dedicated to dermatology and venereology, providing a platform for the brightest minds in research, clinicians, and top industry professionals to come together and share knowledge, make connections, and foster scientific collaboration. The diverse interactive program covering the full AZ of hot topics also includes innovative hands-on workshops, subspecialty sessions, and industry sessions. The exhibition hall will provide opportunities for attendees to explore the latest technologies, treatments, and products in the field to date. The wait is over. Tickets to attend the Congress in Berlin are on sale now. Be sure to check eadvcongress2023.org to learn how to participate and for more information about the event.
Did you know that EADV Clinical Practice has an open call for papers on skin diversity? With a patient-focused approach, EADV's open access journal aims to address the underrepresentation of skin of color in dermatology practice and research. We welcome a wide range of submissions for this special issue, including original and review articles, case reports, and more. Submit your proposal to gaacp@eadv.org. Final manuscript submissions are due by the 30th of November 2023. Don't miss this opportunity to contribute to the representation of all patient populations. Find out more on eadv.org.
if you are looking to stay up to date on skin cancer research and best practices, do not skip this valuable conversation. Enjoy.
Good afternoon to our listeners of the JEADV podcast. Today it's my pleasure that we have Professor John Paoli with us. John is the head of the Dermatology department of the University in Gothenburg in Sweden, and he's one of Europe's experts in skin cancer, melanoma and non-melanoma. And John, we want to talk with you about this today.
Thank you so much for having me, John.
So, John, I saw some recent work of you in the JEADV about basal cell carcinoma, trichoepithelioma, treatment aspects, and epidemiology. And it was interesting for me. You had this work on that we should not only look at the histopathological diagnosis, but also at tumors that are treated right away.
Yes, this is correct. So mainly focusing on low-risk basal cell carcinomas. Of course, high-risk were involved as well. But what we saw in this study was that if we're diagnosing so many basal cell carcinomas now with just dermoscopy, and of course we don't have the resources to be taking biopsies of every single tumor that we remove or treat. So and we found out that looking at the clinical diagnosis and adding these to all the registered histopathological diagnoses, we have many more superficial BCCs, mainly on the trunk and, of course, the extremities as well, many more than we thought previously. And if you look at other data, it always says that the most common basal cell carcinomas are the infiltrative or nodular BCCs in the facial area, but this isn't really true in real life.
Yes, it made me think when I saw it, it made me think of our own practice here in Belgium. So I work in a Northern European country in Belgium, and we see these superficial types, and we also tend not to biopsy every one of them. If we are clinically very sure it's an older patient, we say, we just treat you. We don't make you come back. We don't first biopsy, take stitches, make you come back for treatment. We try to solve the problem right away.
Exactly.
It just came to me while we spoke. Do you see this superficial BCC also in other skin types, or is this something very typical for skin type 1 and 2, phototype 1 and 2?
Well, of course, here in Scandinavia, we mainly have 1s and 2s, but we do have quite a lot of 3s and 4s as well. And I would say that I also worked in Spain for a while, and we saw many superficial BCCs on these patients as well. with a little bit darker skin types. So I think it's not just a problem of Scandinavia or Sweden. It's probably a problem within most populations with a fair skin type in general in the population. Yeah.
So all of Europe.
All of Europe, a large part of the US, Australia, and even many other countries that don't have too dark skin types. Yeah.
Yeah. So it's really a global question to think about
Yes.
it. Okay, that is. And what do you prefer? Curettage surgery? You did also some work about these questions. What would be your approach?
Yes, we together with my doctoral student Eva Backman, who's done impressive work in this field. We've been doing randomized controlled trials looking at simple treatments and simplified versions protocols for destructive therapy of basal cell carcinoma, superficial types, and also the nodular types. And we've seen that that curettage only for superficial BCCs is almost as effective as just cryosurgery. Which was interesting because, of course, cryosurgery isn't available in primary healthcare, for example. So in the future, perhaps we could be teaching, primary care physicians to treat basal cell carcinoma when we just don't have the time to take care of all these patients. And then for nodular BCCs, we were doing testing one session, one freeze-thaw cycle of curettage and cryosurgery versus 2, which is the standard protocol that we have here in Sweden. And it turns out that they're both just as effective, and we might also diminish the wound healing times. So this was also interesting.
So if I understand right, so you were doing either 2 cycles of curettage of a BCC, or you had the patient coming twice for cryosurgery.
Yeah, no. So just to clarify, if we start with the nodular BCCs, our standard protocol has always been curettage, and then cryosurgery, letting it thaw, and then cryosurgery again, letting it thaw once more. And we've tested this versus just letting it freeze and thaw one time. And this was just as effective. So it's saving time, but also saving or shortening the wound healing times. And it's very effective. It's almost 100% after 1 year. Of course, we're going to do further follow-up, 3 and 5 years. But we've already have preliminary results in the 3-year data, and it's really impressive. As effective as surgery on the trunk and extremities, where doing surgery can be quite expensive and difficult for the patient because they have to have stitches for several weeks and big scars and
certainly. I think it's often older, fragile patients,
yes,
maybe even
absolutely.
on anticoagulation, or maybe difficult transport from your home, elderly home coming to. So there are many reasons to have such a practical approach.
Absolutely, we can treat them on the first visit, just as you mentioned, and this is really practical, cheap, affordable. And the patients, when you offer this and you say you can do surgery, and this is you have to come back, then you have to have stitches for 2 weeks, then you have to go to the nurse to remove the stitches, or we can do it right away. And the patients are very happy to just do it right away, and they come back when they have their next one and want cryosurgery again. So it's really simple therapy.
Yeah. So and I have to say we have similar response of our patients. Many of them are happy to have taken it right away. Yeah. And spoken on, you make the diagnosis also with dermoscopy. Which features what in your eyes needs to be present to go for such an immediate approach?
Okay, so it of course has to be a very clear-cut diagnosis. When you're doing curettage, however, you always have the possibility of sending the curettage material for pathology, so you can confirm that what you did was correct. But we've seen in our larger studies within the International Dermoscopy Society that the sensitivity and specificity for diagnosis of BCC is really, really high in many studies, and multivariate analysis showing that we have very high sensitivity specificity. Diagnostic accuracy is excellent. So I'm not afraid to do it without a biopsy. Of course, if there's any little doubt, then of course we biopsy first, or at least send the curettage material for pathology.
Okay, I think that is really interesting, and I think it gives a very good rationale to our colleagues, because this is becoming an epidemic. I have the impression that we see more and more of these lesions. You sometimes also see a patient who kept it for years when it gets a larger tumor. So it's clear that we have to treat it. But I think that is really important that we use our the English
resources
word.
well. Absolutely.
Yes, thank you. The resources. It's
Yes.
the good management of resources. So this looks like a really good example. So, John, I know you also care about melanoma, and
Yes.
that one of your parts of the work is to look at melanoma thickness using dermoscopy and then at the larger management. So
Yes.
maybe you can give us some ideas here.
Yes, wonderful. Thank you so much, Jan. I really like this topic, and it's something that I've been working on quite a lot the past few years, and that I think I will be working on the next decade as well. So really, I think nowadays with dermoscopy, recognizing a melanoma and excising atypical melanocytic lesions that we suspect could be a melanoma, we've reduced the numbers needed to treat from 20, 30 down to, 5, 6 in general, if you look at pigmented lesion experts, and even some dermoscopists down to 2 or 3 lesions. So now the question is rather, okay, can we do the excisions smarter, in a smarter, more cost-effective way? And I think we can. So what we've been doing is looking at, can dermoscopy help us predict the melanoma thickness, if it's a melanoma in situ or if it's a thin, non-ulcerated, less than 1 millimeter thick melanoma with excellent prognosis, or if it's going to be thicker than 1 melanoma. And then you can also predict whether or not sentinel lymph node biopsy is going to be indicated or not. And why is this interesting? Well, today, of course, the standard treatment and what's recommended all over the world, according to international guidelines, is a diagnostic excision with a very small margin, 2 millimeters, 1 to 3 millimeters, depending on the guidelines. And then we have to take the patient back when we confirm the melanoma, if it's invasive, and then remove that with a wide local excision with 1 or 2 centimeters, depending on the Breslow thickness. So this is all fine, but we have to also think about, why are we doing these wide local excisions? We don't really do that for basal cell carcinoma or squamous cell carcinoma. It's only melanoma. And this is, of course, the old tradition from 1950s and 60s where you were excising with 4 centimeters, 5 centimeters, and then reducing this slowly and realizing that we can make it smaller and smaller. And now we're at the point where, do we really need these wide local excisions? And this is, of course, a controversial topic. But now that we can predict, and what we showed in our studies was that we can actually predict with very high accuracy whether or not a melanoma is in situ or thin invasive, or at least not thick invasive. So we can predict that it's not going to need a sentinel node biopsy. So then we can kind of move away from the diagnostic excision with 2 millimeters and perhaps move towards, let's excise it with 5 millimeters, because the clinical margin isn't really all that interesting. The interesting thing is, did we achieve a histopathological margin in the end? And of course, with these small margins that we're removing melanomas with today and historically, we actually have seen that the incomplete excision rate is about 7-10% for melanomas. Some studies say up to 20%. So, we're really mistreating some melanomas. And then we always have to do the wide local excision. But if we remove it with a 5 millimeter margin, and we, thinking this may be in situ or a thin melanoma with very good prognosis, then we'll have a histopathological margin guaranteed of at least 2 millimeters. And 2 millimeters, you might say, okay, that's not much. But in the cell universe, this is about 200 cells. Keratinocytes and melanocytes are about 10 micrometers in width. So you can count that into 2 millimeters and you fit 200 cells. That's quite a margin.
Yeah, definitely.
So if it's not a lentiginous melanoma, then this might be enough. So I would like to do a prospective randomized controlled trial testing whether or not it's safe, and of course, in the future, perhaps unnecessary to do these wide local excisions. This is my goal.
Yeah, I understand. So it's the same approach. Patient comes and you solve the problem right on the spot.
One visit. Yes.
Yeah.
That's the goal.
Yeah. Okay, that is a really ambitious, but I would say a very patient-centric approach. And
it is. Yes.
Yeah, but I understand this will still need years of research. I remember when I was a resident in the beginning of this millennium, I still saw a lot of satellite metastases around excision. So we saw a lot of patients referred to the hospital which had a very small excision, and they had these satellites around the the scar. I don't see such patients anymore.
No.
I think they are nowadays much better taken care of. I have the impression, at least where I work, I don't see
Absolutely.
these patients. Yeah.
I think you and I and probably everyone that's listening today has a similar experience. Here in Sweden, for example, 50% of the melanomas that we diagnose are in situ today, probably more than 50% now. And of the invasive melanomas, about 80% are thin melanomas. So they have excellent prognosis for these melanoma patients. And we're really finding the patients early. The ones that we find late is because the patient is coming late. So if we're seeing earlier and earlier cases, then we're going to have so many more wide local excisions to do. And if these aren't giving any benefits because they don't have satellites, as you say, if they do have a local recurrence or they do have metastasis, is the wide local excision really helping prevent this? We really don't know, and I probably don't think so. I think it's going to be similar to the story with the sentinel node biopsy, where we thought this was going to cure the patients or at least improve overall survival, and then it didn't. So of course, time will tell, but we have to do the studies.
Okay, so that will be really interesting studies, and I hope that you find a lot of collaborators with this. You will need collaborators. Yeah.
Yes, many thousands.
Yeah. So we've been talking a lot about surgery, and is in your eyes the training on dermatosurgery homogeneous across Europe, or do we need initiatives to standardize? I think the same came me when you spoke about dermoscopy. And I mean, you're really making it a diagnostic procedure comparable to a biopsy. So do we need the dermoscopy certification? Do we need some that?
Perhaps not certification necessarily, but it would be a step forward to kind of prove or know which people are trained properly or not. But I do think that dermoscopy training has been ongoing now for quite some time, and there are many initiatives from the EADV, but also from the International Dermoscopy Society, which is a sister society to the EADV. We've been working very hard on this with this issue for many years now, and now it's quite widespread. Of course, there's still a need for improvement, but within surgery, I would say that there's an even larger need, and that the tradition of doing surgery in some countries, I mean, in Germany, where you can't come from, and also Belgium, I think there's excellent training in surgery. In Sweden, I think it's okay. It's not great, but it's okay. But many countries, especially in Eastern Europe, I would say that the training is almost non-existent in several countries. So this is a heterogeneous situation that we should definitely improve in the future with more courses and more education, and also changes in policy and tradition. Just as a crazy example, my colleagues in Denmark, they do the diagnostic excision of a melanoma, but by law, almost, they have to send the wide local excision to a plastic surgeon, even though the dermatologist can do it by themselves, just because the plastic surgeons have had this tradition, So these are traditions that we have to break and change, and yes.
Yeah, I think that's what we need good data for. Good data, yes, and good quality that we deliver. Yeah, not having many complications, having good outcomes, to have the right arguments for the policymakers that this is unnecessary. Yeah, and that, as you just mentioned, that maybe we can just do it at the first visit, or with a short second visit. That would be definitely better.
Yes, yeah. Absolutely, I think so.
Yeah, and how about training? So there's a lot of inhomogeneity, I think, on who does what, and it's very country specific, is my impression. In some countries there's a lot of dermatosurgery. In other countries it's all done by surgeons. So how do we go with that?
Yeah, I think small steps moving forward and thinking in a similar way, and working on making it more homogeneous around Europe. I think the EADV is doing initiatives already towards this. For example, they, just speaking of Mohs surgery, for example, they expanded the number of scholarships from 1 to 4 and fellowship programs for Mohs surgery, for example. And small initiatives like this will slowly change the situation. Of course, we have to move into Eastern Europe, and there I think it's going to be more hands-on. We have to really speak to the people that make the decisions further up to convince them that dermatologists can do this. I mean, in some countries, they weren't even allowed to take a punch biopsy without the permission of a surgeon, and this is crazy, of course.
Now I'm becoming political, but I think
yes.
the big advantage that the dermatologist says, we know the disease, we know the pathology, and I think that really helps in making good decisions which treatments to choose. So I think we really need to make sure that there are enough exchange programs or maybe courses going to a place that you can reach as many persons at one time. Maybe we can have a team organizing a course together at a place where there's less training. Maybe this comes out of this podcast.
I fully agree, and I hope so.
Yeah, John, is there anything that you would say our listeners shall take home? What would be your most important take home? I think we have take-home messages.
Well, I would like to take home or send home the following message. Speaking of melanomas and thin melanomas, especially in situ melanomas, of course, when we see an atypical melanocytic lesion that we think could be a melanoma, but if it is a melanoma, we have to think to ourselves: is it flat? Does it have brown and black features? If there's any vessels, are they dotted vessels? This would all indicate that it's a melanoma in situ. So if it's a melanoma in situ, and that's your best guess, I would say at least remove these with a 5 millimeter margin, because you don't have to worry about sentinel node biopsy. It's never going to happen. Even if it's an invasive melanoma, it's going to be a thin invasive melanoma, right? If you're wrong in that direction. So we can be brave enough to trust our dermoscopy and excise this with a 5 millimeter margin clinically, and this will give us 100% complete excisions. It'll give us 100% complete excisions with a 2 millimeter histopathological margin. So the patient doesn't need any more treatment. So at least we can start with melanoma in situ, only needing one surgery and not another further wide local excision. And then in the future, hopefully we'll move on to thin melanomas. This will take more time, but at least for melanoma in situ, I think we can change the way we treat them. And this is 50% of our patients. It's going to save a lot of time and money. Your patient's going to be happy. And I'm going to be happy if you do it. So please do that.
Happy patients, happy doctors, happy Minister of Health.
Yes.
So I think that you have taught us a lot today. John, thank you very much for joining us. And
thank you so much for having me.
We will meet at another podcast sooner or later, or at the next EADV meeting.
I hope so too, Jan. Thank you so much for inviting me and for everyone that listened. Glad to be a part of this and see you soon.
See you soon, and thank you to our listeners. Bye-bye.
Before you go, a quick favour. If you are a regular listener to our podcast, we would love to hear from you. Your feedback will help us improve the show and develop episodes that you are interested in hearing. To participate in the short survey, simply follow the link in the show notes of this episode. Thank you for your support, it means a lot. We look forward to hearing from you. Until the next episode, take care of your skin.